Welcome everybody. We might get underway. It's almost 9 o'clock. As I said on the first day, given the strange times we live in, this third day is given over to COVID. In the morning here, we have some very important people who've been helping the state get through this difficult time, and we'll have them speak now, get them up one by one, and then we'll have a question and answer session at the end there, a panel discussion. And Associate Professor Roslyn Francis will be organising that for us and taking the questions. You'll have a chance to ask questions. I'd like to thank Russell-Weisz, our DG, who's put in above and beyond. He was here on the first day, he's back here now. We know just how busy these people are at the moment. Our Health Minister had agreed to come on the first and third day again, which was very generous, and we know how passionate he is about research, but not surprisingly, he wasn't able to come. So look, the history of this pandemic and our response to it will be written over the years and so on, and we'll get some sort of perspective. But over a year in now, I think it's probably time for us to hear what's been going on. So with that in mind, I'll invite our first speaker up once again. So it's David Russell-Weisz, our Director General of Health, to speak. Thank you.
Thanks, Gary, and good morning, everybody. I'd like to begin by acknowledging the traditional owners of the land that we're meeting on today, the Whadjuk people of the proud Noongar Nation, and pass my respects onto the elders past, present and emerging. It's an amazing land to share with them. So I said when I opened the conference that I wasn't going to talk about the COVID word. Well, I'm going to mention it quite a bit today. It's obviously been the emergency that's hit the planet over the last 15 to 16 months. We will have experienced it and responded to it slightly differently. And this has been the same for countries and jurisdictions alike. And each response will have been shaped by a number of factors: social, political, economic and geographical. And lived experience of such an outbreak, such as SARS, MERS or Ebola, will no doubt have had a strong bearing on how some countries and populations have responded. And I think, maybe some of the questions will be how have countries been so different? The varying responses and the success or otherwise of these provide important lessons for us all and enable us to refine our own responses to this and future disease outbreaks. I think what's critical is about from here. We can always look back, but how do we shape the future from here? What does it look like this time next year? Because I think, if I take you all back to February 2020, I think we all thought it would be over by about May or June 2021, and it isn't. So I'd like to share some particular insights in the WA health system's response to the COVID pandemic, as well as some personal reflections. So back in sort of January, February last year, I was actually in the States in late January in 2020, and all you could hear was about the Democratic primaries and a little bit about this virus. The stories got more disturbing as we saw this unfold. I think there was a bit, it won't affect us, or it will, like in the past, it will go away. But very quickly, the sorts of stories coming out of China and then Italy could quite easily become our norm. I remember we had a presentation from James Williamson, one of our colleagues, I think back in March. The time sort of escapes me, and it showed the modelling. And I know they'd redone it a number of times, and it showed what was happening in Italy and what could happen here in Western Australia. And it wasn't quite Armageddon, but it felt, I'm sure, you go back and say that model just doesn't look right. And yet we know that models are not necessarily right sometimes, but it really was saying, if this comes, this is what it will do to our hospital, our health system, and what we knew at the time. So by the end of January, the World Health Organization had declared the COVID-19 outbreak a public health emergency, and by March 11, a pandemic status. Authorities all over the world, and coming back to WA, we worked frantically to make sense of the unfolding emergency. And we went through some of the harshest, the harshest restrictions in the state's living history. One of my sort of personal reflections is late on a actually during the day, probably either the Saturday, the 1st of March, it's in here, it's impregnated on my memory. We had to think about how do we respond to this, and was it set up our state incident centre? Was it we do exactly what we'd done before if there was a public health emergency or another emergency, and it felt very different. We knew we needed a public health response, and that we were ready for that, but that had to be adapted. But we needed an operational response. Had bits of paper everywhere, and I phoned a few friends, of which some are here today. One was Robyn Lawrence, who I said, I think I need you to come in and give me a hand. And I phoned a few others, and you know what the rumour mill is like in health. Some actually got told they were coming in before I'd rung them to ask them to come in. So, but they did, and they did in droves. They did when we talked to when we had to have a response to aged care, to mental health, to remote Aboriginal communities, and it was very key that we picked the right people, the people with the skills, and those people who could actually hit the ground running. I remember my wife said to me, I think she thought with all these bits of paper on that Saturday I was overreacting, but for once she said, no, you were right. I think she said that. She said that once. I've written it down. So. She seems to have forgotten recently when I said you were right. So we had a response to the Aboriginal health, remote communities, mental health and aged care, areas that took us into our most vulnerable population. We also knew we needed a new governance structure, one that had that operational arm and that public health arm that came under the Hazard Management Agency, which is health, but which I delegate to the Chief Health Officer, and then had those two arms, operational and public health. And it's had to adapt over time. So we had the state of emergency and a public health state of emergency declared in March 2020, and we're still in both of those. And I think it's really good that we actually invested the time, and this is going back probably 4 years, into a new Public Health Act, and we also put a new Health Services Act in. Both came in within 2 years of each other, 2014 and 2016. It would have been really difficult doing this in with the old legislation that we had. So there was that effort that we put into a new legislation was really worth it. And so we established FEOC and SHIC, and I'm with health professionals, so I can talk lots of acronyms, but we had our public health response and our state health emergency control response as well. Hospital surge measures were put up. Hospitals responded to the initial COVID cases. We did have initial COVID cases in WA by cancelling non-essential surgery, reducing visiting hours, and putting a number of measures in place. We saw a huge increase over that period in telehealth consults, and so some of the work that we were going to do through the Sustainable Health Review actually happened very quickly. We needed to be very agile, and I'll be honest with you, one of the real scary parts of it was our PPE. Australia was at the end of the world supply chain, and WA was at the end of that supply chain. And I remember one Thursday afternoon being told we have enough reagent, or Wednesday afternoon we had enough reagent, and by Thursday morning, no, we didn't. And it wasn't coming. So there are certain things that I have in my mind. I had our Chief Procurement Officer, the Chief Financial Officer from Path West, the Path West Chief Executive, and a few others one Thursday night, literally on the phone looking for reagent. And I think other jurisdictions were in the same boat. But we put a huge amount of effort into making sure we had enough. We needed to guarantee supplies, and we have now got 5 warehouses instead of 1 because we wanted the staff to go, we're safe. We wanted the staff to say, if they're working in hospitals, we get a major outbreak, our hospitals get overloaded, we are safe and we have enough PPE. So we looked at equipment, we got ventilators, and we actually doubled the amount of ventilators. We actually made sure we had a bed surge so that we actually could have enough critical care beds. We went up from around about 121 across public and private definitive critical care beds to around about 670. The WA health system is now the proud owner of almost 2.9 million N95 masks, 1.4 million nasopharyngeal masks, and more than 60 million examination gloves. And I make no excuse for that. We actually had to get on the front foot. We did not know what supply was going to do, and we will obviously have enough for a few years to come, but we will be ready for any major outbreak. We then also started producing our own PPE. And there was a face shields began rolling off a Malaga production line, because we had lots of people approach us. During this, you have lots of people approach you. Have I got a good deal for you? Or I've got these masks, or I've got this. You want the proper gear, and so we were very keen to get. We opened up new supply lines through China, and we brought that in through 3 aircraft. I've been told I'm not allowed to procure any more aircraft, but that was the way to do it. We couldn't rely on normal supply. We had to send 3 A330 Airbuses to get that. We actually made locally made shields. They'd not only received TGA approval, but undergone rigorous testing by the biomedical engineers at East Metropolitan Health Service in their Implant Technology and Retrieval Analysis Centre, known also as CITRA. And it oversaw production and took responsibility for quality control of the product. And I think, you're left at that time in relation to that feeling of fear. There was fear. There was fear in the community, there was fear in the health sector, but we wanted to settle it down. We wanted to make sure we have enough PPE, we have enough ventilators, we're ready. A few words about contact tracing. I wonder how many of the public knew what a contact tracer was when we started. We knew it would be critical. We wasted no time in boosting our capacity in these areas. We deployed and upskilled staff from hospitals and other parts of the health system. We also launched a recruitment drive, and since September last year have equipped more than 400 individuals with the skills needed to perform this all-important work. At the hint of an outbreak, we now have the ability to surge from a base contact tracing workforce of around 50 FTE to as many as 700 tracers. And if you actually see it in action, it is phenomenal to watch. We've seen it recently with the outbreaks in relation to recently the hotel security guard, and then the patient in the Mercure passenger. I call them passenger in the Mercure. And it is really a very, very slick operation to watch. And we will always have that capability because we always have to scale up. We also were able to, back in July, help Victoria and South Australia. And when I was in Northam at the time, we went to the back of the Northam Hospital, new hospital, and they had a number of contact tracers there that were actually contact tracing for Victoria. And that contact tracer, it fails to convey the full breadth of work these individuals perform. They not only advise those being contact to get tested and isolate, but they actually pick through in forensic detail the movement of each contact to identify other potentially exposed individuals. And they're basically like detectives. They've done a phenomenal job. Look at case 903 and look at the cases 984, 986, again on my brain, 1001, 1003 and 1004. I also would like to acknowledge also health support services and everybody in Waypole, the police, everybody who worked on our ICT systems. We put a Safe WA app that hopefully all of you have used today, coming in today, launched last November. The mobile app has enabled businesses to generate their own QR codes, which patrons can then scan. It's very convenient, and it has been hugely useful in our contact tracing. So if there's any message I can say to you, please keep using it. The app and components were scoped, procured, developed, tested and implemented in just 22 days. So, the public sector sometimes get criticised for being slow, but my God, they got their work done in just that time. To date, more than 1.8 million individuals and more than 76,000 businesses has registered for the app, which is averaging 1.7 million scans per day, and last week clocked up more than 200 million check-ins since its release. Focus, PH, not with an F, for focus. We realised our contact tracers needed to be able to undertake contact tracings, and Focus was an IT system which moved from manual, largely paper-based, that actually went to digital. And we actually developed that, procured it, and it's gone through a number of successive upgrades. It's also informed, we think, other states and then how they've procured and how they've developed their own contact tracing apps. For those of you who have ventured out of this state, you will know the G2G app, the G2G Pass and the G2G Now. So the G2G Pass that allows you in and out, and the G2G Pass, G2G Now, which if you are somebody who's doing home quarantine, you have to check in, and you have to check in, the police can actually find you if you're not there. Also, we enabled 15,000 WA staff to work from home over that time. So we got staff home in a very, very quickly. We ramped up our testing, so our testing capability. You have to test, and you have to trace. That is very much, it was a collaboration. This has been a collaboration between public and private in so many ways. We were struggling with testing kits at the time, but we soon got enough reagent here, and we have managed to, as you know, one day we were testing nearly 18,000 tests per day between public and private in one of our outbreaks, and WA Health since the start of the pandemic has performed 1.1 million COVID tests, of which over 150,000 in regional WA. I never thought, as a medical practitioner, training first as a medical practitioner, then as what I'm doing now, that I'd become a hotelier. But that's what we've become. And quarantine hotels is one of the biggest challenges we have. And every jurisdiction has its challenges, but as the Prime Minister has said, it is 99.9% effective. They were not built for quarantine, but it's been a challenge. We've had over 45,000 returning travellers. I'm sure Robyn will talk a little bit more about the challenges of hotel quarantine. They've had to respond up and down. We've gone from 9 hotels to 7, I think maybe even 10 hotels from 7. And the state government and other state governments were very, very quick in actually establishing those hotels. We actually had to establish it over a weekend. Obviously, it's not just about the hotels, it's about infection prevention control. It's actually about the mental health and other well-being of passengers. And it's also about making sure that we can actually have those passengers get to hospitals when they need to. And it's not been that common where we've actually had to get recently passengers to hospitals, but we have in the last 2 or 3 weeks where they have got very sick. We need to look at the future. What does the future look like? Does it look into hotel quarantine? Does it look into home quarantine? Is there a mixture? We've talked about ready-made facilities. We have to be ready for the next pandemic. I just hope we don't forget the learnings over the last few years. And I think one of the biggest sources of anxiety for the WA health system is the early arrival of lots of cruise ships. I'm sure there's people in this room who are attracted to cruise ships. I've never ever wanted to go on a cruise ship and be stuck on a boat with a lot of other people for a long period of time. But some people, we have friends who love it. I'm not sure they love it quite as much as they did, but this was one of the real challenges early on. And with the docking of each potential cruise ship, we had to think about COVID, and with good reason. And I think with the cruise ships, they definitely had challenges for us in relation to the cruise ships, and also we've got so many ports around the state, so we have got a port outbreak plan. We've learned over the last year about how to manage our ships even better. Andy and Robyn will know the figures better than me, but there are thousands of ship movements in and out of ports every year. We've known names like the Artania, the Patricia Oldendorf, the Hark Oldendorf, the Vega Dreams. Well, I thought originally it was the Vegan Dreams, the Key Integrity, and everybody's favourite sheep ship, the Al Messalaya. Maybe distant memories for many, but their names will be incredibly etched into the minds who found themselves at the heart of the pandemic because they were critical to manage. And hopefully we can share some of those learnings. Finally, just a few words on vaccinations. Obviously, we had to change from where we are now to vaccinations. We've now had to make sure we're ready for outbreaks, but also ready to give vaccinations and work with the Commonwealth. Initially, ongoing supply issues, changing clinical advice, changing rules and regulations in relation to AstraZeneca and Pfizer. But we've now done, WA Health has done now, 130,000 Western Australians have had their vaccinations, be it Pfizer or AstraZeneca. And also we're now ramping up through GP clinics and also respiratory clinics that the Commonwealth are doing. We've got four, and I think soon to be 5 major clinics doing, or major centres doing AstraZeneca and some Pfizer. And as more Pfizer comes in, we'll have to be adaptive. We've also had to be adaptive with the Commonwealth as well. The key is obviously to get as many people vaccinated as possible. So it has been, and finally say it has been a challenge, but an inordinate honour to work with colleagues through this pandemic. I think it's taken, I would, on a personal reflection, taken more of my time than I would ever think. I always thought, well, you know, we've got our response, our SHIC response, our FIOC response, but really, in my role, it's taken probably 60 to 70% of my time dealing with the pandemic. But now we've got a system that's busier than ever. Right around nationally, it's busier than ever. We've got ED pressures, we've got hospital pressures, and we're seeing that right around the state. And so we actually have to get back to some of our core business, our core strategy, as well as being vigilant on the pandemic, making sure we get on top of any outbreak, making sure we get people vaccinated. We've got our surge planning ready. So it's not quite juggling, but it's making sure we are not complacent and we have everything in place. So in closing, I think the flexibility of the WA health system has served us well. I will pass one point on. I think there is a no risk appetite out there. There is always, if there are mistakes, there is always a tendency to blame. But when you are dealing with something of this ilk, that we really, some of it is learning as we go with this pandemic. We're here not thinking that we would be here. We think it would all be over 15 months. So I think we need to stand up and say, as we go, mistakes will be made. And not just mistakes, but learnings learnings have to be had. We have to adapt. Every state has to adapt, but I don't think there's any country that anybody else in the world will be in rather than Australia or New Zealand. What I can say is we will continue to learn, we will continue to adapt, and we have to think forward. We have to think forward in a world where people are vaccinated, in a world where there may be some COVID, there's lots of COVID around the world, and about how we open up again. And that is the challenge for the next, probably the next 6 to 12 months. Thank you very much.
Thanks for that overview, Russ. It's fantastic. And just speaking about the WA app, I just got back from Queensland. They have a very attractive app in the shape of the map of Queensland, but it wouldn't allow me to get into public hospitals there. So there you go. Look, in January 2020, if you asked who was the Chief Medical Officer of Australia, you'd probably get a blank stare from most people, or Chief Health Officers or CMOs around the country. We see them on telly most nights, and that includes Dr. Andy Robertson, who is our Chief Health Officer. So Andy, would you like to speak to us, please?
Can you hear me? Yeah, that's better. I'd also like to acknowledge that we are meeting on the lands of the Whadjuk people of the proud Noongar Nation, and I pay my respects to Noongar elders past, present and emerging. I'm going to talk a little slightly differently from Russ around some of the public health objectives, where we went from a public health perspective, and I know Robyn will talk a little bit more on some of the SHIC objectives. So from a public health point of view, our real focus is on how do we prevent unnecessary morbidity, mortality and economic loss during a disaster. It's also around how we actually do it to eliminate that morbidity, mortality and economic loss, a debt directly attributable to mismanagement of disaster relief efforts. So there's sort of two main objectives, i.e. how do we prevent it and how do we make sure our management won't go wrong. As a public health physician, there's obviously a number of things we want to look at, from minimising the risks to the community, identifying events likely to give rise to public health threats, optimising prevented activities, optimising the activities to mitigate the impacts of the public health emergency, and obviously making sure we've got enough people. So in this particular pandemic, we started to get the first inklings in early January that there was something going on, but at that stage it was still very much somebody else's problem. It was sitting in another part of the world. But by mid-January, we started to meet nationally from the Australian Health Protection Committee. We set up our Public Health Emergency Operating Centre on the 23rd of January, and then continued to work But by mid-March, when we started to get a rise, this was around our first wave, we knew that we had a major issue and had to bring in further arrangements. It was no longer a small outbreak that we could manage within our own resources, and that's when we started to see the various states of emergency being declared by mid-March and the State Health Incident Coordination Centre being established. I'll talk a little bit about FEOC, and Robyn, I'm sure, will talk in more depth about SHIC. So FEOC was the public health side of it. Part of it was around that advisory side about providing community information, providing all of the public health advice, and a lot of that was risk-based advice. But it was also to coordinate the public health response, including a lot of the contract tracing functions that Russ has discussed. From a WA point of view, we obviously are the hazard management agency for human epidemics, so we had the lead role as the hazard management agency, but we also have responsibilities under the Public Health Act and as well as the Emergency Management Act. So both of those came into play early on in mid-March, and they were to give us the regulatory background, and we talk about hotel quarantine, we talk about border controls, all of that's done using the powers under those acts. Nationally, there was also quite a lot of work that was done using the acts there. So we've seen the Biosecurity Act. It's still in play. The reason you're not seeing cruise ships here is not because the cruise ships don't want to come, it's because the Biosecurity Act won't actually let them come, unless you happen to have a cruise ship that only takes less than 100 people, and there's quite a few of those out there at the moment. But the lead agency from a national point of view was actually the Australian Health Protection Principal Committee, AHPPC. I think, as Russ said, a number of these organisations, probably if I'd said this 18 months ago, nobody would have had any idea what AHPPC was. And in fact, if I ask who it reports to now, I suspect half the room won't be able to say who it reports to, because RMAC, where it reports to, has actually ceased to exist and has been replaced. But many of the other committees that were in that whole chain have disappeared. But AHPPC took on a key role from the health protection and public health point of view, and ultimately became a subcommittee of National Cabinet. But it wasn't just about health. There was obviously, as we were cranking up in the early stages, there were a lot of considerations from whole of government. And obviously, having the Emergency Management Act with both the State Emergency Coordinator, who's the Commissioner of Police, and ourselves, we actually were needed to look at the broader ramifications of most of the decisions that were being made. So whether that was how do we provide critical supplies, what people forget is that most of the food we get comes across the Nullarbor. So if you close down all of the borders and don't let trucks across, we've got bigger problems than the borders. How do we maintain other essential government services and remembering this is in the lead up to the first wave, how do we maintain communication and public information, transport services, manage our social distancing requirements? So part of that was around how do we frame the event. We needed obviously early on to rapidly implement and evolve early governance arrangements. There's a saying about no plan survives first contact with the enemy. We had all these wonderful plans. We even had a respiratory illness disease emergency response plan. And they were very useful in the early stages in setting up the frameworks. They became less useful after we actually had to start using them because they were, understandably, strategic plans designed at a generic pandemic. This was hardly a generic pandemic. So we needed to rapidly evolve them, and we've obviously got a whole bucket load of plans now. But we also needed to sort out our governance and a clear command and control, given police, ourselves, the Premier and Cabinet and a number of other agencies had a role to play, including the State Disaster Council, which is chaired by the Premier. We also had to deal with a lack of preparedness. As the whole of Western society has moved to a just-in-time supply model, that becomes a problem if you're at the end of the chain, and just-in-time means just-in-time after the rest of the world has got it. So we did have to, and Russ has described, I think, some of the challenges of getting the masks, but there were also challenges in getting a lot of the other equipment, and many of them took months. And then we had to have a role clarity. What was our real role here? Was it as advisors to government? And we obviously had a key role in that spot, and that has continued, but we also had an operational role going forward. One of the first things we did look at was what was our overall strategy. So we started out, where were we going? So obviously we had to get through the first wave, which we did. What were we going to do? We knew at that stage we had no vaccine available, 12 to 18 months. We weren't quite sure what that was being. So a lot of the focus became on how do we suppress this disease? And that was where a lot of the measures, the border controls, a lot of the public health measures were designed to suppress the disease. And we saw the outbreak in Victoria, the second wave in Victoria. What we discovered, however, is that you actually could suppress this disease and we ended up with a national goal of no community transmission. You could actually suppress the disease. Probably harder to do with others. So that actually bought us time. We knew this was always going to be the middle game. This is what we had to do until we got to the end game. And the end game remains the same, which is we needed some form of herd immunity. Now, we could try and do it by natural means. That didn't work well for countries like the UK and Sweden. Or we could do it through vaccination. And that's obviously the approach we're taking at the moment. But we also accept that eventually we will get the population vaccinated and we're going to have to open up again. And this will probably end up as an endemic disease with probably annual boosters, and we just have to accept that, like flu, we're going to have a percentage of people who will get it, and a percentage who will end up in hospital, and a percentage who will die. But that's probably still a way ahead, and we've obviously got to get to that stage over the next 6 to 12 months. From a public health point of view, obviously a lot of the measures you'll know well. I think we've now got a lot more public health physicians, at least armchair ones out there, but there have been some very successful measures. Border controls have worked when they needed to, particularly international ones, hotel quarantine. But I think more recently we've seen how effective testing and contact tracing can be, and it has enabled us to really start to refine. Our approach to outbreaks in the east, our approach to outbreaks here has been refined over time. We didn't close the border over the last 3 or 4 things, and that's because we've got a lot more confidence in both our systems and also in other states' systems. And then we have the joy of imposing restrictions and removing restrictions. I can tell you it's a heck of a lot easier to impose them than it is to remove them. And trying to get that fine balance where we maintain some of the public health measures can be quite challenging. Hospital preparations and community preparations, there's obviously a lot of work going into that. As part of this, there's a lot of planning that went on. We obviously had to do it. A lot of that was based on the modelling, the public health, epidemiological modelling, our learning of the disease. We had a lot of local and national input into that, and we did quite a bit of worst case scenario planning. And some of our decisions early on, we probably don't need 600 or 700 ventilators in the system or ICU beds at the moment. But that was based on obviously what we were estimating at the time. Part of it has obviously been dealing with ambiguity. Everybody sort of assumes that there's... I got asked by the media the other day about, isn't there a template we can use and we can just do that? If this happens, we do that. We didn't know what this disease was like. We didn't know how it was working. We didn't know how it would evolve. And we didn't know the best ways to manage it to begin with. But obviously we've learnt a lot over that period. We needed to collaborate closely with other agencies that to be honest, we've never collaborated as closely with before. I'm regularly getting calls from about schools and how we do cleaning in schools, cleaning on buses, whatever the case may be. Obviously we needed to work within the legislation, which we'd never used in anger. I was involved in the development of the Public Health Act. Part 11 and Part 12 of the Public Health Act, the emergency powers. And we're all saying, we'll never have to use those when we publish, but it's useful to have them. They've become obviously fairly key in the response. The other part is around decision making. Most of our decisions have to be made based on risk. I think as Russ has indicated, there is a low risk appetite often. People don't want any risk. Sorry, but there is always going to be a risk involved. We just have to see if we can minimise that to the degree we can. But basing that obviously on both the evidence that we have, our understanding of that risk process, and obviously to a degree on the risk appetite of government. We obviously need to continue to build our agencies, and then we obviously need to deal with some of the weird and wonderful things that come up operationally. Still wondering why I was asked about face painting. We have to also navigate the law. My role as the Chief Health Officer is as a regulator under the Public Health Act and under a number of other acts. So I have regulatory responsibility. Some of that came to a head in the federal and ultimately the High Court when we defended our decisions around borders and were ultimately successful. But it does highlight the very legal nature of a lot of this work. And then we had to make lots of decisions on a whole range of things, from Rottnest Island, and whether that should be a hotel quarantine, to schools, to easing restrictions, and to our more recently cruise and merchant ships. And I think all of us are probably a bit scarred by cruise ships. And the third point, the next point is around vital relationships. This SHIC, when it was originally envisaged long ago, was a small organisation. If we had 20 people in it, it'd be big. It is a heck of a lot bigger than that now, combined with FEOC. And so we obviously needed to have distributed leadership, a lot of role clarity and freedom of action. Critically, we had to have the right people in the right roles. I'd like to also particularly acknowledge Dr. Robyn Lawrence as the SHIC coordinator. So Robyn's been in that role since, as Russ said, since March. He's going to step down from that role in June. She's done an amazing job in that period and was very much the right person at the right time in that role. I don't think anybody should underestimate how difficult that role is, because it's subject to constant criticism from all walks of life, from the political process to the media process. But she's done an amazing job in that role, and despite what the media, the fictional piece on Saturday's paper, I think Robyn's appreciation was probably best. She was pleased that she managed to get on the front page with the Wiggles. But that and the appreciation of the hard work she'd done. The rest of it was basically media hype. So having those right people was critical, and obviously we have developed very key relationships, particularly with government, to make sure that this and that really is a good example of how health advice can actually feed into government decision making. Russ has discussed briefly the COVID-19 vaccination program. We obviously have a couple of vaccines that we are using at the moment, and they're rolling out with the AstraZeneca over 50 and the Pfizer under 50, it is going to be critical for the end game for people to get vaccinated. There have been some challenges, obviously, particularly with the AstraZeneca vaccine and some of the complications and the rare risks of TTS, but it's something that we need to continue to work through. People's risk appreciation is interesting, and we have to, obviously, vaccine hesitancy has become an issue for us. This is the, you will have seen, and this is the actual strategy. The modelling is actually showing we need to be really at the end of 2A before we can open up to get back to some form of normality. 70 to 80% of the population having completed 2A, and then we can seriously look at opening up the society. We are making progress. We're probably tracking okay, but not as well as other countries. And finally, the thing that we've learned is there's a lot of lessons that we've learned going along. We're constantly being reviewed both at a national state level, and we've got new challenges coming up. We're obviously keen to avoid a third wave, but there's vaccines, the borders, particularly international borders. How do we open up society, and what does 2021 and beyond look like? Thank you.
Thanks for that, Andy. Next speaker is Dr. Robyn Lawrence. I've known Robyn a long time. She's held many senior positions throughout health here in WA. I think she's known as a go-to person when you have a particularly difficult problem. And I endorse all the comments that Andy made concerning Robyn. So I was not the least bit surprised when she was offered and accepted the role of Deputy Chief Health Officer during the pandemic. So Robyn, if you could share your experience, please.
Good morning, everyone. I also would like to acknowledge the traditional owners of the land on which we are meeting today, the Whadjuk people of the Noongar Nation, and pay my respects to their elders past, present and emerging. Thanks, Andy and Gary, both for your very kind words. The bad side of going second and third is that the people who go before you have said everything there is to say. The good side is it will make my talk much quicker and you'll get to morning tea on time. So I wanted to share with you I guess my experience of what it's been like to be the IC through the time in a bit more of a personal way. Andy's already shared some of these slides with you, but essentially the role of the IC is set out and it's quite prescriptive. The role is to provide the overall direction of the emergency management activities in the emergency situation. The authority for control is established in the legislation or in an emergency plan and carries with it the responsibility for tasking, coordinating other organisations in accordance with the needs of the situation. So it is important, it's open to scrutiny, and we fully expect that those people who fulfil those roles in any emergency, whether it's COVID, fire, cyclone, are under very intense scrutiny and in particular circumstances will face the public inquiry into the future. The structure Andy's already outlined, but I thought we could show you on a picture, is relatively standard. So the roles that sit within the SHIC are as you might expect in any emergency situation. If you went to a fire zone and saw what sat within their incident command structure, it would look very similar. In ours, we have the Public Health Emergency Operations Centre also providing that very high level coordination of the public health response, and we coordinate those very closely together. So we are embedded in the Department of Health on the same floor, and we work and attend each other's meetings so that we are fully integrated. FEOCs there also for your, I guess your viewing, just to see the complexity of their structure and how they work. They have similar roles and responsibilities. They also have contact tracing embedded in that structure. Legislative framework I won't dwell on because Andy's already covered that, but again you can see it's quite complex and hierarchical. So when it comes down to who's controlling which pieces, it can get confusing once you get down to is it EMA or Public Health Act. Where is the SEC, where is the CHO in this, where's the incident controller, where's the Sex Coordination Centre sitting within that framework. But I think what we can all say is that over time we've learnt to work really well together, and we've made some really nice friendships and relationships over the 15 months that we've been at this. In the early days it was testy. It was really problematic about who was going to report health data and who should know what when there was an outbreak. But we've navigated that now, and I think we've reached a really happy place where we know who's doing which bits and who should talk to who. And also that we're also in a position that if we're uncomfortable with what one or other agency may be doing, that we're actually got the ability, because of those relationships, to say, hey, what's going on here? And that makes life much, much easier. Andy has picked out the FEOC side of this, but SHIC really is the driving force behind the broader logistics, the broader plan development. We cannot, however, do anything we do without the advice from FEOC. Hence why it had to be absolutely integrated, because I can't develop an outbreak plan without their advice. Everything we do has to be anchored within that public health advice, and making sure you get it at the start and that they're involved in every revision process that you undertake. So very much an integrated service. We've done a lot of things over time, and Andy's mentioned a lot of them, and I'll talk about a few of them in more detail, from sourcing the equipment to the personal protective equipment, getting hotels on board, and leadership and guidance across the health sector. But it is a massive team. So at any one point in time, we've had upwards of 100 people working in the SHIC, and the similar number working in the FEOC, and then many, many working groups out from the clinical realm supporting those, as well as the HSP CE leads and the Department of Health executive. So it is a massive team. And in the early days, you'd come in on a Saturday or a Sunday and you'd find 150 people sitting in the office working, often at 10 o'clock at night. It was relentless. So one of the very, very first things we had to do that we had no idea how to go about, I'll be honest, was setting up hotel quarantine. We had 36 hours notice that Australia was going to move to a hotel quarantine program. There was no guidance. We had to come up with how it was going to work within that time frame, set it up, get a hotel, get the people to run it, and get the people from ships and airports there. We'd never done it. We didn't know what to do. So we set out with some really key principles about what we thought was important. We were already starting to see some of those really key issues, because we were already starting to deal with the Artania. And I'll come to that in a minute. But we knew that we needed to have it close to healthcare workers, because we already knew that these people, particularly the older person, when they got sick, went from looking quite well to desperately ill really quickly. And if you tried to put these people anywhere remote, you were going to have a problem, because you weren't going to be able to respond. We took an early decision that we needed to be able to secure the facilities, and therefore, whether we liked it or not, big facilities where you could secure the perimeter became important. So wide spaced out locations which might allow more access and more freedom and more views and outlook weren't going to be supported. We were concerned about the safety of balconies and opening windows, to be honest, both from the perspective of people getting out and leaving, but also from the aspects of self-harm, and recognising that some of these people were traumatised both by the fact that we were confining them to a hotel, but also that they'd had traumatic experiences in trying to get back to Australia and seeing what was happening overseas. Over that time, we've grown to 9 hotels. We've made many, many changes over that time, but those core principles have never changed. They've been expanded, they've been moulded, they've been modified. But we know a lot more about this disease now, and we know that there's still a lot we don't know. Every time there is a transmission event in a hotel, we have re-looked at it. We had 2 transmission events very early in the piece, back in April, May last year. The first one occurred in one of our very first flights that arrived from Europe. Was its originating place, obviously been via somewhere. It contained a lot of cruise ship passengers from 2 particular cruise ships, and we managed to infect a security guard in the foyer of that hotel. When we had those 2, we thought, this is really odd. What's going on here? And Dr. Paul Armstrong took it to CDNA on our behalf to say, is any other state experiencing this issue? And to be frank, we were poo-pooed. Everyone said, no, you must just have terrible processes. None of us have got that problem. It's all hunky-dory everywhere else in the country. So we went, oh, okay. All right, so we tightened up our processes. We did have CCTV, so we could see exactly what had happened in both of those incidents, and were able to pretty much come up with how they'd got infected. But it wasn't long after that where Victoria ran into its problem. So we did try to learn really on, and we tried to share our lessons with the rest of the country. We then had a very successful period in between where we didn't detect any hotel transmission, and obviously this year things have been slightly more problematic for us, but we continue to learn from each of those experiences as we go on. It remains the highest risk activity in the country, and I think you'll continue to see transmission events. In most states now, between 90 and 100% of hotel quarantine workers are vaccinated. Of course, there's no guarantee that will stop them completely getting COVID, but at least their transmission risk should now be seriously reduced. Ships. Very early on we had the Artania, and as much as we like to think we hate ships, we actually ended up becoming quite attached to the Artania. It was one of those lessons where I'd say it did test my integrity seriously. So as the incident controller, you get multiple messages. They come in by text, they come in by email, they come in by phone call, they come in from a multitude of people with a multitude of agendas. And back in this time frame, not many people will know, but health wasn't really entirely in charge of hotel quarantine establishments. So there were views on what we should do with passengers, where they should go. We had the Vasco da Gama also coming in, which we knew about. So we had 2 huge cruise ships coming in. We knew the Artania was infected. We were hoping the Vasco da Gama wasn't. And we knew our priority had to be focused, therefore, on the Artania. And in the meantime, hotel quarantine's breathing down our neck. The Artania was one of these vessels where you'll probably recall there was a decision taken, this vessel wasn't coming in. Fair enough, the government had taken a decision. The government's able to make those decisions. But at a point in time, I was forced to consider what I was actually going to do. Was I going to comply with this as I saw people getting sicker and sicker on board that vessel? And I went home one night thinking that as a result of our decision making, as a state, that potentially 3 people lost their lives on that vessel. Now, we were very lucky. They received excellent medical care and they survived. But ultimately, I took a decision to bring the vessel in, and I phoned the senior people and said, I'm doing this. I'd rather do the right thing than feel responsible as a healthcare professional for not doing the thing that I thought we really needed to do, which was care for the people who were other people's mothers, brothers, grandparents. And we did, and actually that decision was supported, which was fantastic, and I stood to serve another day in the shik, and I think we got there in the end. But those decisions have come at us continuously throughout this pandemic about what's the right decision, and you get tested each and every single day by, as Andy said, the armchair critics who want you to do one thing, government who has a very strong view and the right to make those decisions, and I guess our inherent background as healthcare professionals about caring for people, using the best evidence you can. Learning from those vessels, and there was quite a lot of learnings, including the fact that actually you can quarantine on a vessel if you do it appropriately, and we've shown that both with the Artania, with the crew who were left on board that vessel, and we quarantined them, and they returned to Germany without any further cases on board, but also subsequently our merchant vessel, and how you can manage those. We managed them really rigorously originally, and we've had to refine that over time, because what we've discovered is probably we could take 2 steps back, and some of the deep cleaning and these other things we'd put in place for merchant vessels probably were not necessarily necessary, and that we could assess vessels on a case-by-case basis about suitability to still come into berth, do their no-touch loading and head back to where they're going, depending on the age profile and the wellness of the crew, etc., etc. Surge planning, Russ and Andy have both really talked about. The scenes of Italy underpin the concerns of all of us, but especially clinicians who are in those fields as they watch colleagues dying in Italy. The modelling showed, as Russ had said, an Armageddon potentially, and we just kept saying this can't be true. Luckily, the modelling, even when we saw what happened in Victoria, wasn't borne out, and presumably that's because of the public health response that sits in the background in Australia that actually moderates the outcomes. So more and more data has been able to be gathered. As a result, we've been able to take those Australian data and actions and keep community transmission low, but also now to start to refine what our modelling looks like for the future and what we need for our surge capacity. So we started, as Andy said, with 600 beds, and we're bringing that down to match what we think is more reasonable, particularly as you go into a vaccinated world. However, we still value the partnerships and will require those partnerships should we ever need a surge. The use of both the public and the private sector to maximise resources across the state and ensure patients get the best care in dedicated, established facilities. So rather than setting up extra ICU beds in a public hospital, you would of course use dedicated ICU beds in a private hospital. So those partnerships are key to any response, and we will continue to work through that and develop them as we look forward, but continuing to refine the numbers and how we would deal with it into the future. PPE and equipment, we've probably touched on this enough, but it was a major issue and it has never really gone away. It just changes in focus. So many people in the audience may know that we're experiencing a shortage in wraps for sterilisation in theatres at the present. It's a global issue, it's certainly an Australia-wide issue. It's not driven by COVID directly, but it is indirectly because the material that's used for the wraps is also used for gowns. And so the whole world's bought up gowns, you get an incident in a major factory and actually your whole supply chain gets disrupted. So we're continuously looking at things that are hitting that kind of issue. Drugs, so enoxaparin's another one that currently is in short supply because of an issue in manufacturing. And again, it's being used massively in COVID management, I believe, so that's impacted. India's now on our horizon, what comes out of India. So that supply chain is constantly having to be reviewed. And in the background, what we're now looking at is what might be going out of date. What can you use? Can you force people to use the fact that we've got a year's use of hand gel and they don't like some of it? So there's things like that we're having to work through as well so that we try to minimise wastage. I think it's fair to say the work just never really ends in a pandemic. There's always something to come back to. Outbreak plans, as Andy said, we had lots of plans and frameworks and they did set us in good stead as a starting point, but we actually didn't have any dedicated plans for specific situations and we had to build those from scratch. So needless to say, we started with the overarching integrated outbreak plan and we went on to develop a range of specific plans. At the time, I think it was fair to say people didn't think they were quick enough, decisive enough, shared enough, a whole range of things. People also expected them to be a cookie cutter, and what we've seen from every little outbreak we've had so far is there is absolutely no such thing as a cookie cutter. They still are a framework, they give excellent guidance, but actually every step still has to be guided by public health decision making set on the specific circumstances. They continue to be regularly reviewed, and obviously now we're looking at them in light of vaccination, and we will continue to do that for as long as we're in operation. Somebody did ask me what will we do with them when we eventually close down the SHIC for the next pandemic, and I said I actually don't really know that because these have been crafted really specifically for COVID and they may not suit the next pandemic. But what they will do is provide a framework for the sorts of things you actually need to start to look at early in the pandemic, whatever it may be, for those specific circumstances and settings where special care and special options are required. Despite everything, I think it's fair to say that when something happens, people forget there's a plan. So people will recall Collie a couple of weeks ago where there was a big hoo-ha, someone's got COVID. Sitting in the background, we thought that was highly unlikely. We could see the results. We thought it was probably going to be a historic case, which we're pretty certain of. The gentleman had COVID, we knew that. Yet schools started to shut. That's not part of the COVID plan. They just did it. And they've all got the plans, they all knew them. Luckily, Andy did receive a phone call and he was able to calm it down. But in the chaos and panic that occurs, people still respond. So it's been an interesting journey and it's one that I don't regret, but certainly it's been pretty testing at times. And I'm looking forward to my break and to handing over to Dr. Tudor, who will take on the responsibility from here. Thank you.
Thanks, Robyn. It's fascinating and given us some insight into some of the difficult decisions that had to be made. Look, as we've heard from the speakers, I mean, this is not a health problem, or it's much broader than that. And so our next speaker, Mr. Peter Klinken, he is the Chief Scientist for Western Australia, and he'll talk about some of the broader issues that came up. Thank you, Peter.
I've obviously upset Gary because he's just demoted me from Professor to Mister.
Thank you, Professor.
Sorry to have upset you, Gary. Can I start off by saying kaya nuna kot nija wajak nunga muja nun kadich nunga pretty mum and pretty yoga kura waya nija dunjurpan nija. So hello everybody in the language of the Noongar people. Very pleased to be here today and I acknowledge their elders past and present. Crikey, how do you follow an act like that? Russ, Andy, Robyn, thank you. I just think we've had a tour de force, haven't we, of how to handle a serious situation. And I mean, it's just hard to say thank you enough. I think you guys have been superb. I feel a bit of an imposter to be up here, to be perfectly honest, because I didn't have any direct role in COVID. As you can see by legislation and everything else, that there's no sign of a chief scientist in all of this. But what happened to me was really organic, and it was quite surprising, to be perfectly honest. I can remember very clearly, I think it was either the first Friday or the second Friday of March last year, my phone was just going nuts. I was getting text messages, a bit like Robyn was saying, I was getting LinkedIn messages, emails, and people I didn't know, companies I didn't know were just getting in touch with me. And the common theme was, COVID's coming. You could feel the fear, you could almost feel the panic, and they were going, we're here to help. What can we do? I had no idea. So I rang Roger Cook the next day, and he said, Pete, I think you better talk to Russ. So that was on the Saturday. I'll never forget the conversation with Russ on Sunday. And he said, we need 4 things: PPE, sanitisers, swabs, and ventilators. So I emailed back all the people who'd got in touch with me. And I've got to say, I didn't know most of them. They'd never met either, right? So I said, here's the list of things. And by Monday afternoon, they'd made the first prototype face shields. So if you think about it, from Friday where they contacted me to Monday afternoon, they'd actually made the first prototypes. So that on Tuesday, I was able to walk in to Liz McLeod's office and say, here, what do you think of these? It was quite remarkable. So Brendan Kennedy, who worked at UWA and the Harry Perkins Institute, got in touch with Faz Pollard, who works with Adash, Adash manufacturing company, and Glenn Ryan from Sunnovate. These guys had never met, but they just wanted to roll their arms up and roll their sleeves up and say, how can we help? So it was fantastic to see the speed with which that happened, the ability to then take it up to the health department and go, here are things that need to be modified, blah, blah, blah. It's really rapid. And then David Morrison, as Russ mentioned, at Royal Perth, looked at the modifications, how can we do this better? And it got accelerated authorisation from the TGA, which was fantastic, right? And so I think 10,000 of these face shields were manufactured in Malaga, and it's just, for me, it's one of the most uplifting experiences that I've had in my life, to be perfectly honest. Another one that was really relevant was a company called Wild Child Laboratories. They got in touch with me 3 weeks before the pandemic was coming, and I thought, these guys have got to be medicinal cannabis producers, right? With a name like that. But in actual fact, they actually produced sanitisers, and they were in Malaga, for crying out loud, right? I go, okay, so here we go, coming into COVID. There's a company up in Malaga. They were able to get in touch with the health department and provide sanitisers. Another wonderful outcome. The third one that also blows me away was with ventilators. I called a Zoom or a team meeting, that first week after I'd been contacted. And about 30 people came online. The word just spread really quickly amongst the manufacturing community about a need for ventilators. And they were all putting their hands up, and so I had some ICU specialists like Jeff Dobb online, and we were saying, well, what can we do to help? And 4 companies just put their hands up and said, right, we'll drop everything, right? And we will try and make ventilators because it looks like there's going to be a shortage. So let's make some prototype ventilators based on what we see on the internet, right? We've never made a ventilator before, but we'll have a crack at it. So the groups were Curtin University's engineering department, Tejas Battaglia, Lyndon Vikinger from a company called Vical, and Vical make luxury yachts. All right, and you go, WTF, seriously, what on earth is how does a luxury yacht company get into this space? And they said, we make bilge pumps. We pump water out of ships, we can pump oxygen into people. Not a problem, right? So they went off and made one prototype. Another company, MZ3, just a bespoke manufacturing company, said, well, we'll have a crack at that model. Another company, ASW, Australian Steel and Wire Company, I mean, seriously? You know, he said, we'll have a crack at that model. And so all of it behind the scenes, these companies just went off and started trying to make ventilators. And where they couldn't actually get parts because supply chains had been cut off, other companies were saying, we can 3D print that for you. And so there was this incredible community that developed trying to make ventilators behind the scenes. And in the end, all 4 of them made the ventilators. All 4 of them were tested by Jane Pillow at UWA and by Jeff Dobb at Royal Perth, and all were successful. They're not ICU quality, but they certainly would have been useful. Fortunately, as Russ mentioned, we were able to get a whole bunch more ventilators, and we didn't actually ever need to mass produce these. But the capability was there. So a number of lessons for me came out of this. One, how good is it when the community just goes, they put their hands up and go, we're here to help, we don't know what to do, how can we help? And I guess I was in a role where they'd seen the name of a chief scientist and they used me as a person to contact. And I was able to then make contact with various government agencies and so on to make this happen. It was incredibly uplifting. Sadly for me, as we've come out of COVID and the supply chains have been reintroduced, our local manufacturers who are keen to continue on in this space haven't been able to get into the supply chains. And so that's something I think we need to work towards, about making sure that we do have sovereign capability. As Robyn said, you know, we've got external sources. We also need to make sure that we have sovereign capability in these areas. So that was uplifting. Another one that was a real surprise to me was on the first Thursday of lockdown. My mobile goes off and I say, oh, Ben Wyatt. Treasurer's ringing. What? That's unusual. Doesn't normally call me. He said, Peter, do you think the universities can help us with this COVID? Oh, absolutely. I'm sure they can. He said, right, you've got 24 hours to come back with a series of projects for me. 24 hours, right? So I rang around to all the universities, to all the vice-chancellors and the deputy vice-chancellors of research, and within 24, by the next morning, I had 36 really, really good projects that I was able to say to the Treasurer, we have got some serious capability in the state that can address these issues for you. A number of those were specific for each university, so you know, based on their strengths, and those projects, you know, given the tick. But there were a bunch of them that actually were common themes across all the universities. For example, data analytics, mental health, and Aboriginal health. So I was able to convince the Treasurer to say, well, let's get all the universities working together on these topics. And he was really comfortable with that. So by the Monday, $5 million was then allocated to the university sector to do this work. And then it was handed over to Department of Jobs, Tourism, Science and Innovation. They worked out incredibly quickly an efficient way of financing this and administering it, and so the work was able to be undertaken really quickly. So some really key learnings from all of this for me were, this is different to the normal model of saying, you know, we've got a bucket of money, give us your best ideas, and you know, we'll rank you, and 10 to 15% of you who are successful will get the money. This was really different in that here is an issue, a specific issue that government says we need addressed, and they're saying, you guys come back and give us the ways that you can help us. This might be a new model, to be perfectly honest, for a government and university interaction or researchers interaction, and it's, I think, probably a more efficient and more collaborative way. So a new trust has been developed, I think, between certainly the government agencies and the universities around all of this work. I've been calling for a single University of Perth for the longest time with 4 different campuses, and this to me highlights how if we actually combine our efforts, we work together collaboratively, we can do so much more. The competition really is global, not local. We shouldn't be wasting time with internecine warfare. And here is a model whereby we can all work together for the good of our community. So out of a really, really challenging period, through COVID, I've been uplifted. I've seen some wonderful initiatives. I've seen some disappointments too, to be perfectly honest, where there were a bunch of charlatans, as Russ said. There was there were people who were coming up saying, "Well, we've got a deal for you, brother," or people actually saying, "I'm going to stockpile all of those things that you need for face shields, and we'll sell it to you at a premium." And you go, "Come on, really?" It highlighted the really good parts of human nature and some of the less enduring qualities. So I'll stop there because I know everyone's dying to get to morning tea, but it's not over yet. We're still trying to work our way through great opportunities. Some of the testing work that's being done here has just been phenomenal. We've got a company that's now selling rapid robotic machines to Spain and Hungary based on technology that's been developed here. We're looking at new drugs being developed here in WA, the Australian Phenome Centre. I think we're hearing from Jeremy this afternoon. He's done a phenomenal job in the biochemical analyses, and we're now looking at mRNA vaccines being produced in WA. So I'm going on to a Zoom meeting on Friday with all the other chief scientists in Australia to see what can be done locally. We do need sovereign capability. Let's not pretend that we can just rely on things to be shipped in at the very last minute. We do need to look after ourselves. We do have the capability. We do have people who want to help, and this is our moment to bring it all together, I think, for the good of our future. So on that note, I'll say Borda Wandanuk Jinung. I'll see you later. Thank you.
Right, look, thanks. That's been absolutely fascinating. I'll invite Associate Professor Roslyn Francis now up here, and she's going to allow you to ask questions over the next 10 to 15 minutes. So there's microphones here, and over to you, Ros.
Thank you, and I'd also like to extend my thanks to all of the speakers. It's actually been an incredibly fascinating insight, I think everyone will agree, into the complexity, responsibility and resourcefulness of the team that's been leading us. So thank you all very much for that. I have a couple of questions here, but I'm just wondering, is there any questions in the audience? And yeah, if you can come forward to the microphone.
I'd like to just make a comment from the laboratory's perspective. So I don't think there's any debate that we've done extraordinarily well in our response to the epidemic. Some of my less generous colleagues over east would say that we've just been lucky, and it's true, we're protected by the rabbit-proof fence and the nullarbor plane. But the other thing is we have a single public pathology service, whereas a lot of the other states don't have. And we have had weekly teleconferences throughout the epidemic where all the labs sort of give psychotherapy to each other. And the constant message I got from over east that the health department didn't tell them anything. Most of their requests for increased resourcing to have appropriate responses were knocked back. And I had to honestly say, well, we've actually had excellent relationships with the health department, particularly from the point of view of communication. And we always got the response, tell us what you need to do what we need. And I think that just has to be acknowledged, that the resourcing to the health community has been enormous. Thank you.
Thank you, and I think that's great feedback as well for the level of communication and a very collegiate approach within the state, which has been great to hear. It's great to hear that personal experience as well. As we are more than 1 year on since the pandemic, and we have a little time to reflect, although it sounds like none of you have had much time at all because there's always one crisis after another, it would be really interesting to learn about what you think has been the most important thing in retrospect that you think either went well, or perhaps if you were doing it again, you would definitely focus on going forward, and has maybe put us in a position going forward where we are more prepared. Is there something that you've really reflected on yourselves that you've thought has gone particularly well, or if you were doing it again, you might have done slightly differently?
I think it's actually quite basic. It's right. It was the right people at the right time. And I think it is that collaboration between the agencies. Andy and Robyn have both touched on it. But we have lived and breathed this with police. So the State Emergency Coordinator is in charge. So if there ever is a decision to be made, and who can overrule everybody else is the Police Commissioner. And I think you've had people in the room who haven't brought their egos to the room. There are some really difficult problems. I think I've spent more time with Andy and Chris Dawson than I've spent with my family, and I'd say probably the same with Andy and with Robyn as well. But really 8 a.m. and some days they're every day. And I think it's a fact. You just have those wicked problems and you try and work them out, and you try and marry sometimes the politics with the operational, with the public health, with the clinical ramifications, with the community ramifications, and you're constantly. So I think any learning is actually right people, right approach, and probably an adaptive governance to make sure, because what we have now is actually, whilst Robyn showed on that chart, what we had is actually not what we started with. What we started with, we're thinking, well, that ain't going to work for this pandemic. And I think you'll see probably something quite different in 12 months' time.
So, Andy and Robyn, I was just, with Western Australia being such a geographically isolated but also challenging state in that there is actually a very large land mass with some population challenges, has it both been a challenge and an opportunity in trying to manage COVID amongst our geographic environment?
Look, I think it has. There are obviously the challenges of being able to provide services, across a very large landmass. But there are also, the advantages as well. We don't have to deal with outbreaks. We don't have to deal with very porous borders. You think about the New South Wales-Victoria border. The reality is there's more goes across in an hour there than probably goes across in a month across the Nullarbor. And so we do have some, I suppose, levers that we could utilise, particularly during the second wave and things like that we could utilise to protect our population. But there are challenges more broadly at providing those services, protecting Aboriginal communities in the broader area, and we've managed to do that. And also to provide, whether it's testing services or contact tracing, once we get into some of the more remote regional areas and things like that.
So, question from the floor, thank you.
Okay, look, thank you again for keeping us safe. I mean, I think you'll have done a phenomenal job, and I guess I've got two questions, but it's probably the first one is more humanistic. I'm really interested how you all have managed, this is over a year, to make sure that you all have stayed sane in your families, because, we've had the opportunity, I'm speaking for myself, of discovering WA, and it's fabulous. But I just can't imagine that you all have had any time off to kind of just enjoy the state that we're in, that you've kept us safe. So that was really my main question. I mean, the other one is obviously, how we're moving forward to get our community to understand how important vaccination is, because we can't really move until they do that. And maybe, you need think of a lot more help from other sources. And I can tell you, for example, people that run netball clubs and in schools, I mean, this is a bit of a joke, but it's not really, the reality is there are lots of fantastic people who actually can get to the community and make them change, because they're in schools and they're in various other places. And we probably just need to think out of the box, out of health, to get that help. So thank you.
Thanks. So there was a question there about vaccination and the strategy towards getting the population vaccinated. There has again been, as we've said, some challenges with the AstraZeneca thrombosis issues and the change in advice, which again I think reflected a learning as we got more information and a risk-modified approach, as we've heard. But the vaccination strategy, do any of you want to comment on that?
Yep. Yeah. Vaccination sits with us at the present time, and I think there are challenges, and there's the starting point challenge is it's a joint state Commonwealth process, and who's running the comms and making sure that they, I guess, marry together nicely is more challenging than it might appear on the surface. And getting information out, and the Commonwealth puts one set of information out, and sometimes they don't tell us what they're putting out in advance, so then people go to access it because the Commonwealth said that they could get access to the vaccine and they can't. So those sorts of things are helpful, but not always as you would like. I think what's becoming clear is vaccines in arms is the most critical thing, and we've created multiple queues by the hierarchy, which would have worked well if we'd had a lot more vaccine up front, but because now we've got this ongoing tail and the media is really quick to tell you any negative story that they hear on the grapevine, some of which are related to the vaccine but some which aren't, but they don't balance it with the positives about getting vaccinated. So very quickly we're coming to a strategy which says, actually the sooner we can remove barriers, which means remove the hierarchies, the better. But because those hierarchies are there, and in particular we are concerned about the group of under 50s who are high risk, so the disabled people and those with chronic medical conditions who haven't yet had access to vaccination, and the workers in residential and disability care facilities, that we do want to give them an opportunity, but as soon as that opportunity has been out there for a period and we're seeing slots continuing to remain available, I think all states will move to open access based on age until there's more vaccine available, and then eventually I think that age will disappear and we'll move to complete open access. Andy?
I think the other thing to round out the question is that I think once, we have had supply issues, particularly with the Pfizer, obviously some hesitancy around the AstraZeneca vaccine. But I think we will get to a stage later in the year, whether that's August or September, when all of a sudden we're going to have a lot more Pfizer. We'll still have good quantities of AstraZeneca, and it's that stage I would suspect that we'll start to see the opening up. And all of a sudden, there will be things you can do if you've had the vaccine, and there'll be things you can't do, and including some of the flights and airlines. And all of a sudden, if half the population discovers that they can now go to Bali, for example, but they have to have a vaccine, we'll probably get killed in the rush. Is the reality of it, it's not impacting on people's lives at the moment. It's impacting on our lives, but not on people's lives. But as soon as that changes, I think we will see that uptake escalate, and the vaccine hesitancy will start to wane. There'll still be some around, particularly around AstraZeneca, because of the risk, the risk argument. But I think with others it'll disappear.
Peter?
Just wondering if I can add a little bit. I think people forget how quickly these vaccines have come out. It has just been breathtaking that within a year we've got a half a dozen different varieties of vaccines that are out there. And who had heard of mRNA vaccines a year ago? This is a brand new category of vaccines that is going to be widespread. This has been done at breakneck speed. And so if there are a few glitches along the way, there are learnings. There's no doubt about it. But we should not forget how incredibly rapidly this response has been.
So we had, thanks for those insights, which are actually incredibly valuable, I think, and for us to be able to learn from. We did have a question from Barry Marshall as well, through Gary. He unfortunately couldn't make it today, but he has a question for the panel from Professor Barry Marshall, and that was to do with the sewage testing. So, or is that a bad question?
No.
But we're just curious as to whether you think it has a role or what that role might be. Or is that a difficult question?
Look, I think the answer is yes, it does have a role, but probably the role has been overplayed in certain areas. Okay. So, look, I think I've watched various East Coast states chase sewerage positives up and down the coast, as trying to work out why all of a sudden it's positive in Byron Bay or it's positive in there. And then they look and they test everybody in those communities and find nothing. And there's also a role of the shedders in, we're seeing more and more, people have had historical cases and are still shedding, and and it's probably somebody stopped in Byron Bay on their way up the coast and used the facilities, and that can cause panic. So it's trying to get that balance between where it's useful. So obviously in Victoria it was useful during some of their outbreaks where they were able to target certain areas, and in Sydney where they said we need to look in the Bowral area and things like that. So being able to target testing, but just because you've got a single test positive in a coastal town doesn't mean that you've got a major outbreak there. And so it's really about how we use it, and probably not. It's not putting. It's useful as an adjunct tool to all of the other things that have been doing, including the more critical testing of the population.
So in Western Australia we are using it, but in a rational way, by the sound of it.
And we've got positive, periodically we get positive results in the Subiaco wastewater facility, which drains from the CBD.
Okay, sounds reasonable.
And we've got cases in the CBD in our hotel quarantine, and we'd expect them to. And so we know it works, we can pick it up, but we haven't seen anything outside that.
Excellent. Is there any other questions from the floor at all? Yep, do you want to come forward to the microphone?
Good morning, everyone. My name's Carly. I've been involved in the Consumer and Community Involvement Program for a number of years and feel very blessed to be here today, and I'd like to affirm the government about how you've responded to COVID in WA. And one thing that I'm curious about is that we've now seen that a whole of government response is possible in addressing things like a pandemic, and I was pleased to hear when Professor Klinken said that the universities are collaborating and working together in research areas, and I'm just wondering and curious about whether in WA it would be possible to have an all-of-government response to mental health and suicide prevention.
They all look at me. Look, I think. It's a great question. I think you've seen the focus the Commonwealth government have now put on mental health, and I would, if you go back to 2019, and I've talked about this extensively. One of the second enduring strategy in the Sustainable Health Review is mental health, and I don't think there's a bigger, more important area that we need to concentrate on over the next 5 to 10 years, and probably longer. There's not a quick fix. I mentioned in my talk, we're seeing demand go through the roof. Now, we actually saw demand in mental health be very, very high pre-COVID. It then dropped, as everything dropped, but now we're seeing it, go way above age-weighted population growth. You've mentioned suicide, depression, also eating disorders. We have seen, I don't even know what the fold increase in eating disorders is, but it is national. The thing is, when I talk to government, and remember there is a mental health commission, the mental health commission purchases mental health services, we work very closely. I think you'd have to say there is a joined up approach. It can always be better. But we have to be better at the narrative with government. I think mental health is harder when we talk to government because some of it is unknown. If I asked, well, why are you seeing this massive increase in eating disorders, for example, I'd have to say, I don't know, and I'm not a mental health professional, and I think we need to say, well, we don't know. I think you will get more focus. One, you've got huge focus in this state on mental health, and when I say mental health, that's not just acute mental health beds. That's right the way from community through to units that support patients who don't need to be in acute hospital but can't be in the community, to secure units, to acute, and to probably our most vulnerable population, that's prison health, to forensics as well. So it's a spectrum. Has to be joined up. We have to invest in that subacute more than others. So I think you will get it from the state, and I think you will get it from the Commonwealth. The Commonwealth have got 3 big items at the moment: aged care, mental health and disability. So it's a great question. I've tried to give you a reasonable answer, but it has to be painted as a long-term journey. There is no quick fix.
Okay, I just looked at Gary and he gave me the nod. So I think with that, it will be time to wrap up this session. But I just, again, would like everyone to join me in thanking all of our speakers this morning, not only for your time this morning and sharing your incredible insights. I think we'll all go away quite humbled by your contribution and really grateful. But yeah, thanks so much for your time this morning and coming and sharing that with us, and for everything you've done for the state. So thank you very much.